Hello and welcome on this sunny spring Wednesday evening. I am Humphrey Hawksley and this is Care Vision's professional talks and podcast, where specialist peer groups discuss issues on health and social care that are critical to all our lives. And the talks bit refers to communication, how professionals talk to each other, but also how they talk to civilians like me in a language that I can understand. Now, today's professional talk is What We Fear Most, the title of the book by my guest, written under the pseudonym of Ben Cave, What We Fear Most, a psychiatrist's journey into the heart of madness. His work for more than 30 years has been in prisons and secure hospitals, diagnosing and treating some of the most troubled people in society. How does that work? What impact do these tragic and frightening experiences have on those health workers in the front lines? Hear the stories, tell your own stories, ask questions, put it all in the chat, and we will bring them into the conversation, whip up a discussion, and welcome not Ben Cave, but the real one, Dr. Humphrey Needham-Bennett, to Care Vision's Professional Talks.
Good evening, Humphrey. It's a pleasure to be with you, and it's lovely to meet another Humphrey.
It is. I think we're going to get very confused during our talk. I think you're the first one I've met for at least 20 years. Certainly had an interview
Well,
with.
you too. We should form a support group for survivors of the name.
We should. There could be some psychiatric impacts of being called Humphrey too, but that is not the topic of our discussion. But I want to sort of for the civilians amongst us, Humphrey, what is the difference between a forensic psychiatrist, which you are, against a normal psychiatrist?
Okay. Well, normally people ask what the difference is between psychology and psychiatry, but I think your audience probably are fully aware of that. So, psychiatrists are doctors who then specialize in psychiatry, just as a surgeon becomes a surgeon, an eye surgeon specializes in eyes. I did, what was it, 7, 8 years of postgraduate training to get through to my consultancy and specialist registration as a general psychiatrist. Then I spent another 3 years as an old-fashioned senior registrar, becoming a forensic psychiatrist. You could bypass the general psychiatry route, but I've ended up being a sort of a broad-based specialist with specialisms in general, forensic, and substance misuse and rehabilitation. So I have accreditations in all those areas.
What is the forensic part of it? Because when I think of forensic, I think of crime novels and police taking fingerprints.
Yes, absolutely. Cracker and such like, although he was a forensic psychologist.
Yeah.
Forensic psychiatry is, I think the word comes from the forum. It's the place of justice, and it's the interface between the criminal justice system and mental health services. So I work at the divide, and it sort of gets to the heart of the old-fashioned dichotomy of mad or bad. And that's where I sit. And I most of my professional career, certainly as a consultant in the NHS, I worked in a medium secure unit, and prior to that I was working in Belmarsh Prison, which is a high security prison in Woolwich in southeast London.
Okay, well, I will want to return to that sort of crossroads between between mad or bad, as you say. But I wanted to talk a little bit about your own background, because I think when we last spoke, you said that when you were a kid, you wanted to be a pilot up there exploring the skies, and you end up
Yes.
a psychiatrist exploring the human brain. How did that come about?
Well, it was probably just yeah, it's a very good question, actually. I think it was a way of escaping from home, if I'm being truthful. I think I was probably about 10 years old, and I was seeing the planes going into Ringway Airport, which is now Manchester Airport, of course. And I was fascinated by the whole concept of flight, but very quickly transpired that I'd have been a terrible pilot because I'm colorblind. So no doubt I would have crashed. And then I sort of discovered actually my proper vocation, which was medicine.
And the psychiatric element of that, because you join up to become a doctor or whatever, and then you decide to do your speciality. Why did you choose psychiatry and not orthopedics?
Well, I was one of those rare creatures that probably did medicine in order to become a psychiatrist. So I Well, I was a very anxious and rather obsessional child. There's plenty of reasons for that, but I'd sort of kind of had to work out my own way of managing my obsessional compulsive disorder, which was very significant. And I then thought, well, I might as well become a psychiatrist because I can do this. I just wished I'd written up the therapeutic process. I'd have been famous.
Sorry, go into that a little bit. You had a compulsive obsessive disorder, and
Hmm.
explain that and your family and how all that meshed together to make you become what you are.
Goodness. It was a perfectly normal, loving family. Let me put that on record first of all. My mother came from a very troubled family in terms of health issues, and her brother took his own life by suicide when she was 18. He was a late teenager, I think. She had a couple of younger brothers, one of whom nowadays would be described as autistic, and the other had a learning disability from a perinatal injury. So I think in the immediate aftermath of her brother's death, she also lost a mother. So we had suicide and bereavement for her. And I think that set the tone for something of a neurotically anxious, depressive picture. And maybe there was some sort of, the apple not falling far from the tree. I don't know whether there was a genetic component to my particular problems. God knows, I think that anxiety and OCD in childhood are terribly common. I think probably it was living in the pool of suicide in the family, being very inhibited in terms of talking about emotional issues, not being allowed to. My mother being terribly anxious about physical health problems. And I suppose psychiatry and medicine was my rebellion.
Yes, and to understand yourself and your family environment and how all that was going to, which brings us on to to the wider topic. And please, for our audience out there, if you've got any questions to ask Humphrey, not myself, please put it in the chat and we will put it in because this is going to be a fascinating conversation. Care Visions, which is the umbrella of professional talks. Its skill set is with children and young adults. And you just talked about yourself being a child growing up in this environment. Give us an idea of how a child's brain develops and how, now that you're older than that, how you can stop trouble brewing and what you do about it.
Gosh, that's one of the most difficult questions. I'm not a child and adolescent specialist, but I would say this. Almost everybody I see who has dependency problems, complex trauma, personality disorders, they've always had issues that are hugely important to them in their developmental pathways. Stable, secure development is, I think, premised on having good enough parents. I think that's the analytic way of describing it, perhaps. And I think it's absolutely true. They just need to be good enough and having stable caregivers. The patients that I see have complex disorders, and they very often have mental illness intermixed with personality disorders and usually another comorbidity, whether it's borderline IQ or substance misuse. So they are, by definition, complex, and all of them, to a man, and most of them, 90% of them are men, they've had really difficult, troubled childhoods. They've had unstable care attachments. They've been put in care. They've often described abuse from people they should be able to trust. I saw one chap who had, we x-rayed his chest for some reason. I think he had a chest infection, and we saw multiple broken ribs. And I said, look, what's going on? What's that about? And he said, oh, it was when I was a kid. It was nothing. I was just beaten up. And it was his parents who had done it systematically. So those are conditions I'm sure your audience will be sadly familiar with. But it lays the foundations, the seeds, if you like, for that developmental pathway being skewed. Um, I think we all have great goodness within us, and most of my patients don't want to be in the position that they are in. And yet they find themselves sometimes inexplicably, from their point of view, doing really terrible things. And sometimes it's because of their personality, sometimes because it's the demons they carry from their personal traumas, and sometimes it's mental illness coupled with substances.
At what age? I mean, I'm going to ask you a series of impossible questions, actually,
Yes,
here,
I
because
get the idea.
at what age does a brain develop to such that it's more difficult to treat? So if a child is in that dreadful situation that you've just described or similar, I mean, 5 years old, 7 years old, 13 years old, 21 years old, is there a time to catch them and get them out of that environment and they might have a better chance?
Would it be at the zygote stage? Would that be too early, perhaps, in utero?
Oh,
Um,
really?
oh, goodness, yes. I
Yeah.
mean, when children are born, they come out in many ways fully formed. They are not the empty vessel that traditional psychology used to think they were. They bring a lot of themselves into the world and then are shaped by their social experience through the prism of genetic expression. So I think that literally, quite literally, from the day they are conceived, their brains are developing. And when your first experience is a heroin withdrawal state at the point of birth, it's not a great outlook, is it?
And then if you are in that situation, the chances are that the people around you are not going to be the best people to sort of take you out
Quite
of it.
possibly. I mean, I don't want to, demonize people who use drugs, but it often the substance misuse disorders often coexist with something of an anti-authoritarian attitude, difficulty getting on in society, and sometimes a pattern of repeated offending simply to get hold of the drugs. For women, that's often prostitution. For men, it's robbery and theft, typically, and I'm using sexual stereotypes, but by and large, they hold true.
So so this is a real civilian question, but when you get your patient there, so it is mainly it's not nature. They're not born with so it's mainly nurture. It's mainly the environment they've come up with that has created their psychiatric problems.
I think it's a generalization, but by and large, I think that's true. I do see patients who have had some sort of brain insult, acquired brain injuries in adulthood, perinatal injuries. I saw one chap who was a serial killer and a prolific rapist, and he actually had a big cystic lesion where his left amygdala should be arguably the point where the external world meets the internal. And in a sense, he was an organically disordered autist, and he just didn't understand people
Right.
and was trying to work out how they worked, and in the process was killing them. So it was really quite awful and terrible. But sometimes you see people where there's no clear explanation or rationale for their appalling actions, and arguably they're the primary psychopaths. But mostly it's a matter of adverse life experience and intergenerational trauma admixed with the substances, learning disability, and mental illness. And I don't think anything is a given. And hopefully, by addressing the problems early, giving them remedial help, support, input, Head Start programs, educational support, focusing on early truancy, behavioral problems in childhood, then we can actually then identify the kids who are going to have problems later on. And that's what I think medicine and psychiatry do very badly. They're very bad. They're very good at treating end stage problems, but very bad at treating things prophylactically.
Yes,
And I think
because the if you have a child in care, for example, going through that system there, people like not yourself because that's not your speciality, but there would be your colleagues and peers brought in to detect this and then to treat it. Whereas if they're with their families, that might not happen. That they might not have that.
Well, I think one of the central themes of child and adolescent psychiatry is you can't really treat the child in isolation from the family. So it's an absolutely important and vital component that when you address the problems of the child, you address the problems of the family, because usually they are one and the same thing.
Yes.
The child's expression of disorder, whatever that is often symptomatic of the family problem.
Yeah, take the we've got some questions coming, so I just wanted to. In fact, I'll give the questions because then I want to ask you. I want you to give us an idea of what it's like walking into Belmarsh Prison and talking to and someone. But Ross says, how do you continue to work with people who have done terrible things and still hold them as okay with a value? How do you look after yourself given the trauma you have expected and what you have supported people through? Ross, thank you for that, but we are going to talk about that exactly after we've heard about your experience in Belmarsh, because that's going to be exactly what it is. Why do you think the majority of people affected are males? Asks Leslie Punter.
Probably biology, probably hormonal, probably size, probably because of social pressure. And I think historically the male is the more aggressive of the sexes, and we play true to form. Men are violent and aggressive, and if you want to then shape the pattern of that, you can do so through the prism of mental illness and threat control, override symptoms, paranoia, and throw in a bit of dependency, be it alcohol in the context of intoxication or opiates in the context of withdrawal states, and it's a recipe for violence. I think women are catching up. Certainly in the domestic setting, some of the research coming out of America shows women being much more violent in statistical terms than people used to think. So that's kind of bucking the trend of the social expectation of women not being violent. But unfortunately for women, they're smaller, and usually if there's a scrap between a man and woman, the woman comes off worse necessarily. It's just the way of things.
But they don't scrap.
Oh, they do.
They do, do they?
My experience of men and women being violent to me personally is that men hit you and you can sort of see it coming, and women hit you in the back.
Oh, okay.
And it's a terrible, crude oversimplification, but that's my personal experience. And if you look at the defenses to homicide, there's some truth in that, because actually women have to pick their moments when to be violent.
Yes, yes.
So I say it lightheartedly, but there's a real truth
Yeah.
underpinning it, in fact.
And Alan MacDonald, is it possible for the brain to rewire itself or store away trauma experience?
Yes, no, maybe.
Maybe.
Well, yes, no, maybe. I'm being absolutely definitive in that answer.
Do we have an idea? Because I mean, we do hostile environment courses, and that when I was a journalist, and is that you have to process the trauma, and
Yeah,
if you don't process it, it hangs around. But if you can process it, usually by talking
yeah.
about it or something, it can become part and parcel of everything.
Yeah, that's a metaphor, I think, and an important one. I used to, when I was doing cognitive analytic therapy for my patients, I used to talk about the black box where people store up their problems, their demons, their pressures, their traumas. And I think to the uninitiated counselor or therapist, they want to get in and open up the boxes. And my job was often to help them get some nails and keep it shut, firmly shut, because you open those up at your risk. And sometimes patients can't cope with what they discover or what they find. We have a remarkable facility to repress and suppress memories. Um, that opens up the whole field of recovered memories, and that's a debatable issue. But I think what is absolutely real is that people do cope and have great, productive, and happy lives, albeit with that black box approach.
And do
Um,
we all have a black box in us?
Yeah, absolutely. Well, most of us, I
Yeah.
imagine, do. I'm sure I do in some ways, and I keep, a lot of work-based experiences there. The plasticity your questioner raises is an interesting one, though, and I think the brain can rewire. I mean, certainly, I think the brain is more plastic, certainly at a younger age, and I think we see evidence of that after neurological damage, and I think people can relearn things and adapt to that process. It's a complex area,
Yeah,
which is why I gave such a vague and awful answer from the start.
that's no, that's right. We are drilling down, as we say, but it's really fascinating. Could you now? We're going to pause the questions for a moment. We've got a lot in there. Could you now give us an idea of your day at work? How do you get into Belmarsh? How do you know what you're going to see? How do you keep yourself safe? You've talked about people hitting you. Just give us a picture of that.
I was there for 2 years as a research fellow, and I was looking at pathways to offending in a dependent population. Um, you go in with the prison officers, you go through an airlock, you go into an internal atrium. There's very little signage. I think many people will have been into prison and know how custodial, how restrictive, how institutionalizing they are. I was working in our healthcare center, which I should say is by definition not a hospital, which is vitally important in terms of our ability to treat people coercively. You can't treat people under the Mental Health Act in a healthcare center. So we had to transfer people out unless they were so unwell we could treat them under the common law. So I would go up some old metal stairs up to the healthcare center. We had about, at the time, 30 inpatient beds. Probably about half of them were people who had physical disabilities, needed physical problems, victims of assault. I remember vividly one chap who had hot water mixed with sugar thrown over him, and it had taken most of the skin off his face. You couldn't actually tell what color he was looking at him. And so a lot of physical health problems. And then I had probably about 10 to 15 people who were acutely mentally unwell with either drug psychoses, mania, or paranoid schizophrenia. Usually, first onset psychoses were desperately common. Prisons, hugely restrictive environments, paranoia inducing, massive variation in the quality of the staff. It's not something I would feel I would be able to cope with.
Yeah.
I was carrying a set of keys in a pouch on my waist, and I would sometimes just pat them to make sure they were there.
You
Um,
were by yourself, or did you have a minder or a guard with you? Or
no, you have the run of the place. You're inducted. It's a bit like going into Broadmoor, and you go on an induction process. You learn how to use the keys. You learn security measures. You identify pretty early on who the people at risk are. And if you are worried, and certainly I write about this in the book in terms of the alarm systems, and so once when I set it off by accident, people come running to your help and support. But no, you're left to your own devices as basically a senior clinician to make the decision as to how you see people. If you wanted to see somebody supported by other officers, and sometimes if they were being violent, you'd have been crazy not to, obviously. Then yeah, you'd have six people in Kevlar and truncheons and bite-proof gloves with you, and then you'd
and
try and talk to them.
and give us an idea of one of the most impactful patients that you had, your treatment of that person, how the impression it left on you, whether it was a success or a failure.
Um, there were two cases, I think. One was profoundly affecting because he was a gentleman well, he wasn't a gentleman, he was a violent man. And he had been systematically abused in his developmental pathway in his childhood and early adolescence. He'd been sexually abused. He had fallen foul of drugs. He was a hardened criminal by his late teens, early 20s. He had a serious personality disorder, and I think he was psychotic as well. And he was, because of extreme violence to a prison officer, I think he'd broken somebody's arm, he was put in what amounted to a padded cell. It was a special seclusion room with rubberized walls and floor. And I remember going in to see him. And again, I write about this in the book. And he said, if you fucking talk to me, I'm going to bite my tongue off. And I spoke to him. I introduced myself and I got as far as the Bennett part of my name, and he put his tongue out and he took the end of it off with his incisors. I'm sorry if any of the audience are eating at this point. So I had a gentleman then spit his little bit of gristled tongue at me, and I remember it bobbling down onto the toe caps of my shoe. And then I saw the crimson blood spreading on the pink floor. And it was really quite a surreal experience. And I remember dissociating because of the bizarre nature of this. And I was thinking, goodness, what am I going to do, basically? And I was being watched. I was safe. I had people above me and behind me. So there was no risk to myself. I should have said he was actually in a body belt at this point. And I was thinking, what do I do next? So I make sure that he's safe, he's in the recovery position. We try to stem the bleeding, but nobody in their right mind is going to put their fingers in his mouth. And I go off to talk to the ear, nose, throat surgeon at the local hospital. And I say, I've got this guy who's bitten his tongue off. And he says, no, that's physically impossible. So I go, no, it's not. Not when you're psychotic.
You show him the grizzled bit.
I felt I didn't have it at that point. But yeah, I probably should have done. I should have held it up and said, haha, look, it's true.
And how would you, what was your diagnosis of him?
Oh, I sent him off to Broadmoor. He spent about 8 or 9 years there. He had a psychopathic personality disorder, and he'd been using what was a precursor to spice. So it was a very sort of powerful psychedelic, and he was under the influence, no doubt, when he did it. It is possible to damage yourself like that. I once had a chap who was purely manic, no evidence of drugs whatsoever, and he had a compound fracture of his femur. And I remember literally having to rugby tackle him as he stomped out of the emergency department, where he'd been brought by the ambulance crew and police. And he had no perception of pain. So that chap who bit his tongue off, he actually got treatment and support, but I don't think it would fundamentally affect his long-term risk. Let me tell you a happy story to counter that, though, if I may. There was another chap, and I was asked by the nurse to see him because she said, he's looking a little bit pale, doctor. And I went, oh, do I have to see him now? It's going home time. And she said, yeah, I think you should come and see him. So I did, and he was so white, he was like an alabaster statue. There can't have been any hemoglobin in his system. And I said, what's going on? And then I realized what was going on because I kicked the mug underneath the bed, and normally prisoners kept some water or soup or tea in it, and actually it was full of blood. And he had dissected the muscle here, the palmaris longus, and he had a cut here, and you could actually peel back and feel the artery.
Oh my God.
And he was systematically bleeding himself, and because it was a slow process, his body had adapted to this appalling level of anemia. So his hemoglobin came back at about 3.5, which is pretty critical, and we sent him off to A&E. I then got him out to Grendon, and he had group therapy, and he did brilliantly. And again, guess what? It was personality, it was personal trauma. It was now probably where we're going with complex trauma.
Yeah. So this is a run-of-the-mill prison. I know Broadmoor's slightly different, but Belmarsh and these other places are prisons that criminals go to. What percentage of people in there have got mental health problems and that they're in there because they have mental health problems. And should they be in there? Should they be somewhere else?
Yeah, it's a very good question. Let's say there are about 700 people, probably more than that these days, on an average day at Belmarsh. It's a mixed remand, high turnover prison, but it's also got Cat A, and some long-termers go there. I reckon that at any given moment, there are probably about 20 or 30 of them who are profoundly psychotic. And you could probably, certainly of the patients coming in, about a third of them had a significant substance misuse disorder. And I reckon probably a third or so you could actually diagnose some sort of abnormal personality traits, if not a disorder. So it sort of depends what type of mental disorder you're talking about, but the levels are high, astronomically high for mental illness in prisons. I wrote a satirical essay looking at we should be swapping the prisons with the healthcare service, and actually everyone who goes into prison, we ought to be dealing with their healthcare problems assertively and
Right.
actively.
Yeah. And you said somewhere, I think in the book, that is it 11% of the murders, homicides committed,
Yeah.
people have mental health problems, but which means that 89% people don't. What is the impossible question? What is the difference between somebody that has a mental health problem and kills and somebody who doesn't? Because killing is not a natural thing for hopefully anybody that's listening to this show at the moment.
Well, arguably, it's a very natural thing for aggressive animals to do. And actually, the remarkable thing I believe is how come there's so little homicide in England, Scotland, Ireland, and Wales? Most of the statistics I'm familiar with come from England and Wales. Scotland do their own statistics, but on average, there's about over the Great Britain, there's around 700 homicides per annum. People who are picked up for murder, and that we know very well the rates of mental disorder, because actually the overwhelming number of people who commit murder are actually caught. So there's a very high cleanup rate for it, thankfully.
Mhm. Mhm.
Now, counterpoint, first of all, the 700 with the 30,000 a year in South Africa, or the 40,000 or so that happens in Mexico, probably largely drug driven because of the cartels.
Mhm.
So you have systematic violence which supports their industrial processing of drugs. So back to this country, when you are charged with murder, many people will say, well, instead of getting a mandatory life sentence, I want to try and get a diminished responsibility plea. And that means that the judge doesn't have a requirement to sentence you to life. They have discretion in the process. You might get a discretionary life sentence anyway, but you don't have to. The judge could then give you a determinate sentence, or indeed a hospital order, on the back of a diminished responsibility plea. And we know, and the statistics are remarkably similar over the last 20 or 30 years, 10 or 11% of people are successful in their diminished responsibility by dint of mental illness.
And this is, to get back right to the beginning, this is where you come in at that crossroads between health and the justice system.
Yes, absolutely.
Yeah.
Now, we know the background rate of schizophrenia is about 1%.
Mm.
So the interesting thing is that actually among serious criminals or serious crimes of extreme violence, the rate is greatly increased. So there does appear to be a functional link between schizophrenia and violence, but still the overwhelming majority of people who commit murder are not mentally ill. And that's the important thing. Most people committing murder are perfectly normal people like you and me. Well, I assume you're normal.
I'm not going to go out this evening on the spring evening, but I want to go back to Ross's question,
Yeah.
which was how people, that you work with, can you hold them as okay with values, and how do you look after yourself? And
Yeah.
and please, any colleagues, peers of Humphrey Needham who've had this experience, put it in the comments so that we can, if you've had these experiences, let us know. Humphrey, how do you look after yourself?
um, well, how do I look after myself? That's a good one. I I'm not sure I did that well. I was a pretty heavy smoker until my 30s. And then I'm pretty sure I probably drank more than was good for me or sensible. I don't drink at all now. Um, it wasn't something that you would define as a disorder, but it was certainly an unhealthy attachment to alcohol. And I think a lot of clinicians who work with patients find some sort of outlet. One of the things that really helped me, though, was my wife buying me a cycling jumper because I'd always liked cycling. And then I got into triathlon, and then I got into long distance triathlon, and now I continue with open water swimming. So I found my outlet through, extreme sort of long distance events, and I was never particularly fast, but I just kept tabbing and enjoyed that. What else? I like swimming, skiing. So I go skiing whenever I can.
So your outlet after your smoking and your drinking, your outlet was sort of hobbies and exercise, fresh air.
Sports and family, and just seeing normal people and having a barbecue at the weekend with loved ones.
Yeah. And if you've had a day where you've had a guy biting his tongue off or whatever a dreadful thing it might be, it's not the sort of thing that you can go down the pub and talk to your mates about or even talk to the family about, is it? And so you do keep that bottled up.
Well, yes, to an extent. And I suppose that certainly when I was working in prison, and perhaps towards the latter end of my career, I did start to suffer something of an existential crisis about the nature of humanity and what sort of people we were. I remember having a fairly specific and extreme threat from a patient I was treating who was a very violent and prolific offender. And he said, Dr. Needham-Bennett, make no mistake, when I get out of here, I will kill you. And that went, that chilled me. The other experience that I had, and I write about it in What We Fear Most, was a chap who was a convicted rapist who I sent out to Broadmoor basically on the last day of a 7-year stretch. And I did so not lightly because there was something of the double jeopardy, but I told him the day before he was sent, just so that he knew what was going on. I wanted to keep him fully informed. And one of the very lovely prison officers I worked with, the senior officer, Tchaikovsky, in fact, spoke to me the next day and said, I think you better come and see his cell. And my name was written in very small letters all the way around the cell, not once, but it went round 10 times. And it was just Dr. Needham-Bennett, Dr. Needham-Bennett, Dr. Needham-Bennett. And I sort of went round it, and there was no denouement, there was no threat at the end, but it was absolutely chilling. And I got a very expensive alarm system at that point linked to the local police force.
Can I give you Ross the first bit of Ross's question there? People who've done terrible things. Can you still hold them okay as sort of people, or how do you think of them?
Can I answer that by way of another example?
Yes, you may. Yeah.
I saw a gentleman who was charged but not convicted at the time with very serious offending against children. And he came into the healthcare centre that I've described. This was much later now, and I was seeing him as an outside expert, and he came into the healthcare centre very traumatized after he had been beaten up. Other prisoners, because of the nature of his offence, alleged offence, they had beaten him up, broken an arm, and then they'd stood around and urinated over him. And this guy came in shaking. He was traumatized. He was trying to kill himself, and on one occasion came very close to successfully killing himself pre-trial. He went to trial and he was found not guilty. And my first impression at that point was lucky bastard, because I thought he was guilty. His family thought he was guilty. Frankly, everybody thought he was guilty. A year later, there was DNA evidence that compellingly and conclusively rebutted the charge, and he was an innocent man wrongly accused, and everybody had got it wrong. Now, I appreciate that's the tip of the iceberg, but I treated him professionally, but I was somewhat cold in my demeanor to him. I did everything right, but it was without the spirit of warmth and humanity that I should have put into it. And I kind of made myself a promise at that point that you have to treat people with humanity, because these are the most underprivileged group in our society, bar none. And how we treat them is a testament to our society and how we deal with our fellow man. And I actually don't care what people have done. They deserve to be treated with respect, with dignity. And if we ever hope to rehabilitate them, and the overwhelming number of people in prisons will be released into society, we need to treat them right. Because
Yeah.
otherwise, we're just going to re-traumatize them. They're going to come out. They're going to reoffend. It's not rocket science.
But you have to keep that value, as Ross was saying. What is we have Philip Cody, I think this is. Phil Cody, does it feel easier for you to think of the illness, not the person, as the problem when there is a clear mental illness, than when the contributing factors are less clearly diagnosable as illness? The illness and the person.
Yeah. I think that's a fair comment. I probably do. And I think certainly in the earlier part of my career as a sort of very biologically driven doctor, I think that would have been a fair critique of my process. And in a way, it's a defense position as well, because the closer you get to somebody as an individual, as a person, as a living, breathing creature who has feelings like you do, the more you empathize and the more difficult it is to detach and provide a professional level of care. Now, very often I would treat their mental illness and I would try and treat it aggressively to the best of my ability. And very often that sorted out the problem. So my job was actually to get them well enough to then have the therapy. And without my input, they wouldn't have been able to form those bonds and relationships in group or individual work. So I don't think what I was doing was less valid. It was just a different part of the same cycle to get them well.
So when you say as a psychiatrist you get them well enough and then they go on to a sort of therapy, a journey to get them back into society, you say and that's done through drugs mainly, it's not done through you talking to them.
Yeah, but by definition, if someone's deluded, that you're not going to be able to talk them out of it. It's not amenable to a psychotherapeutic approach. I think those concepts have died, decades ago, frankly. The typical patient that I would see would be manic, irritable, aggressive, violent, paranoid, hearing voices, believing that you were trying to kill them. I would get people well, and then later on they might say, yeah, when you took your glasses off, doctor, that meant you were about to hit me, and that's why I sort of raised my fist to you. And they're very open about it. So they regain insight into their disorders. And we know that neuroatypicality, we know that drugs, and we know that adverse life experience and social pressures are all push you towards psychotic experience. So you have to treat the psychosis first. And I think in the sense it's important to diagnose those people, because that's a shorthand way of understanding that problem and communicating it to other doctors.
Yeah.
But then that's the beginning of the interesting process. The medicine is usually easy.
Yeah.
It's
And
what
then
happens
seeing,
later. That's the difficult bit.
which gives a question from Stuart. Given it was your passion that drew you to this field of work, how do you process the negative outcomes or the sense of futility with some of the patients that you work intimately with?
It's hard to bear. That's the honest answer. I can't say otherwise. That there was one gentleman who I worked very closely with, and he had a treatment-resistant schizophrenic illness, and I wanted him on clozapine, which is a fairly toxic drug, but it can have remarkable positive effects for people with treatment-resistant psychosis. But it has numerous side effects as well, so it's not something you do lightly. I got a second opinion. I took, I spoke to other clinicians and colleagues about it, and eventually we forced him to have it, and injectables were just coming in, so he didn't really have a choice about it. Unfortunately, as he was getting better from his psychosis, he started to get serious side effects from the clozapine. Now, at this point, he approached me and said, I want to continue with the clozapine. I don't want to go back to that hellish nightmare place of psychosis. And I said, well, sadly, I'm worried that you might die if you carry on with the clozapine. So we'd actually changed positions from me wanting him on treatment and him not wanting it. We'd swapped over. We'd both done a U-turn, and I eventually did stop the medication, but he died a few days later. Not from complications, as it turned out, from clozapine, but because he had a very rare form of pneumonia, and he was under medical care for a long period. But I remember telling his mother what had happened and why, and going through it with her, and she was a very beautiful and gracious person, notwithstanding the fact which had just lost her beloved son. But he had had probably 20 years of unremitting psychosis by that point, and he was clutching at any straw we could offer him. So yeah, you handle those failures hard, but actually that's the nature of medicine, and people die, sadly, and there are difficult outcomes. So it's all the balancing act between what you can do safely, trying not to do harm, but if you do no harm at all, you're never going to do any good either.
Are the drugs getting any better, any more? Because you're being a psychiatrist is slightly different, isn't it, to being somebody that fixes a hand or a leg? Because you can operate, you can X-ray, you can do all sorts of things, but you're dealing with this. I think, as you said at the beginning, this hugely complex thing that we've got up here. Are the drugs getting any more forensic, for want of a better word, that you know that what you're treating, and or are they still quite scattergun?
I don't know what you mean by scattergun. Are the drugs getting better? Arguably, they have different side effect profiles. We've moved on to the atypical antipsychotics. I'm not sure necessarily they're better. I don't think we've had that eureka moment in psychiatry. In many ways, I think we're barely out of the Middle Ages. I think neuropsychiatry in the future will revolutionize psychiatry, and I think we will then get smart drugs that target specific types of schizophrenia. When we are describing schizophrenia, I strongly suspect it's a spectrum disorder, and there are different types of it with different severities and prognoses. Just like diabetes, just like rheumatoid arthritis, just like blood pressure, there's different causes for it, and we can, we're starting to get to grips with that. I think in terms of cancer, it's probably a better model than orthopedic surgery, because orthopedics, you either cut it out or it heals by itself, largely in spite of what the doctor does sometimes.
Yeah.
I think with cancer, we've got that concept now of living with cancer, and I think people will live better with mental illness if it's assertively treated.
Mm-hmm.
And so often, because of social stigma and because of failure of the treating agencies, we're not assertively treating them, and that's shame on the country, basically.
Yeah.
That really troubles me, and I see, by and large now, and this is a sweeping generalization, but a true one, we see a failing health system.
Yeah, yeah, and in many areas, but here, and you've been on the front line of this particular thing. Joe says, I think you've touched on it, but I will say the question, and you can say a bit. How can you bear it that people you came to know are in an awful place for maybe the rest of their life?
I think the people who are stuck in that awful place for the rest of their life are a very small minority, thankfully, these days. I don't want you to come away from this talk as being pessimistic. I see the worst of the worst. I see the end stage cancer. I see the people crippled by disease, very often who haven't had that initial habilitative process that most people in professional roles take for granted. So when I see people, I don't mean this crudely, but they are feral in many ways. They haven't had that process of social indoctrination, of comforting role models. They don't know which way is up in terms of how to interact with people, and they've got a mental illness. When I came out of forensic psychiatry and did general psychiatry, I saw people who get better, and they get better pretty quickly, and they stay better, usually with the medication. Sometimes they stop it, they relapse, they choose not to have the medication. But actually, the days of, the unsalvageable person in the asylum, I think it's largely dead and gone. And I think the prognosis in that regard is infinitely better than it used to be. So
Yeah.
I don't think we can or should write people off. We are still learning. It's a profession, I think, genuinely in its infancy. We've only just discovered the mental equivalent of the circulation of the blood, but we're now starting to see brains. We can scan them, we can see them real time. We're starting to understand and get to grips with how they function, and I think that will revolutionize psychiatry in the future.
Alan MacDonald, can significant mental health be influenced by both cultural and structural violence? Not quite sure what that question means. Do you get it, Humphrey?
I'd be happy to know what you mean by cultural and was it social?
Yes.
Um, I would need some backstory.
Alan, give us another line on it, because I was wondering whether you were a professional talking in Humphrey's language, but give us another line. Danny Henderson, there is at least a perception that mental health issues are becoming more prevalent. To what extent do you think that's accurate, and to what extent might this relate to the medicalization of societal dysfunction wrought on by modernity? Good question, Danny. Yes.
Yeah, I think we are picking up more mental illness, sometimes because it's actually there and we were missing it. Partly it's a screening process, and I think that's to be welcomed by and large. I don't think there is more schizophrenia or bipolar than there ever used to be. I think people are getting better at diagnosing it. People like Stephen Fry destigmatizing bipolar disorders. That's all good, and people will come forwards. And instead of those episodes of weirdness that were sort of written off as, I don't know what, they just went a bit mad, we can actually treat them and get them on mood stabilizers, low dose antipsychotics. They can actually understand their illness. If they want medication, that's great. If they don't, we can work around it. There is a genuine, though, problem in terms of medicalizing society's ills. And I think that comes to the fore with depression. And for years, we were saying we should be treating depression assertively with antidepressants. I don't think it works. I think it's a crock of nonsense. I think antidepressants are effective and largely safe when they are targeted at people with what I would call a biological type depression. That's the sort of the moderate or the severe depressions, not the vicissitudes of normal life that we all suffer from time to time.
And are you not a sort of living example? Because you said that you were smoking and drinking too much. So obviously this whole job was getting you down a bit. And then your wife gave you a bicycle, you start swimming, you mountain climb, you sing in a choir or whatever it is. And that fixed your depression or whatever it was that you were suffering from.
Well, I don't sing in a choir, that's for sure. That would be awful.
I just threw that in, but
No, absolutely. I had to rebut that immediately. We Ask me another question, Humphrey. I'll come back to that.
Yeah. So, well, I mean, I think it's sort of, and I wanted to come back, and my goodness, the hour is going quickly. We have one from LL I've got up here. From your experience, how much does the lack of mental health services and supports within the community impact on reoffending rates and or escalating levels of violence?
It does. I think that by and large, forensic services in England, which is the services I'm familiar with, are pretty good when it comes to forensic services. That said, I think I see an increasing trend to see people's problems based on capacity rather than mental illness. So if they have capacity and they say, I don't want treatment, then they are cut free from the services. I think there's a tick box mentality creeping into the process. And I think we are judged in terms of our own efficacy, not on the reoffending rates, which arguably would be a more interesting measure, but how many people we see, inpatient lengths of stay. Short is good, long is bad. And we have clearly a shortfall when it comes to community psychiatry nurses working in the community. They're as rare as hen's teeth. We need far more of them, and they're all working far too hard in difficult circumstances with too many difficult patients. We think nothing about releasing prisoners at the end of their sentence, and we accept that there is going to be a reoffending rate. We don't preventatively detain people because we think they're risky. And it's interesting to counterpoint that with mental disorder. And most people with mental disorder are not violent, of course. Some are, but the overwhelming majority are not. So is there an epidemic of crime or violence or social malaise or problems because of mental illness being not treated? No, I don't think so. That would be naively simplistic. Far more important in that is the issue of people's personalities and how it links to substance misuse. If you wanted to control crime, you'd do something about the huge rates of alcohol and substance misuse in the country. Both of them are high. They're becoming ever greater. Drugs are getting cheaper, which is usually a very good marker for their availability and supply. And the rates of violence and substance misuse in women is approaching now that of men. So there is greater social, sexual equality between the sexes, and that's going to drive up the rates of violence as women catch up.
Can I, a very quick last question with a quick answer, please, because we are almost out of time. Leslie Punt, who I think was our first questioner, actually. In your experience, do young teens who are on medication for mental health issues remain so for the rest of their lives in order to function well? So if you get given a drug as a teenager, is that it for life?
No, not necessarily. It depends what it's being given for. I do worry about the amount of drugs that my child and adolescent psychiatry colleagues give. I think, it's meant to be a short answer, but we get onto the attention deficit disorder issues. I think that is important to treat. It's apposite that people do get the treatment they need. I think that has been underdiagnosed in the past, but arguably it's now being self-diagnosed and people very often don't have it, or the positive effect from the drugs would be marginal. So I think that comes back to good parenting and what I said first, and having the good enough parents. Put simply, pick your parents carefully. That's my advice.
Pick your parents carefully. So the in the womb you have to you have to sort that out. And I'm going to come back to you for a second for a final thought, Humphrey. But Time's winged chariot is attacking us, and we're almost out of time. And I have been taken on a roller coaster journey in this past hour into Belmarsh, into wider issues there. And I do hope that you have all got as much out of it as I have. What we fear most, the links to the book and everything. Yes, that's it. Great. We've got the book there. The links are in the chat if you want to give it a click. And Humphrey's website, but it's not his website, it's Ben Cave's website. But thank you so much. But before you go, just give us a final thought on this whole issue that we've been discussing, something that we can take away with us into this spring evening.
We're treating more people better than we did. Psychiatry has a very ignoble past. We're getting better at it. We're learning. And I think if it was a teacher's report card, we'd sort of probably be getting a B+, needs to work on various neuropsychiatry issues, but on the whole, shows promise.
Yeah. And what are you doing now? You're not still going into prisons, are you?
I do sometimes. I do medico-legal work. I do CQC work as a second opinion appointed doctor. I sit on tribunals, and I spend weeks and weeks out in France up mountains.
Oh, and that's that antidote that you have. But that's it, everybody. Thank you for being here. Thank you for your questions and your comments, like them. And we are particularly grateful to Dr. Humphrey Needham-Bennett for fielding everything that has been hurled at you by myself and the audience. Thanks, Humphrey, so much.
Thank you.
Thank you. And I learned so much, and I hope all of you did. Our next professional talks is on May the 29th at 7 p.m. with John Whitwell. He's had a lifetime in childcare, and he is a pioneer of therapeutic communities. How can we ensure that an emotionally injured child does not fall through the gaps? Do you know about therapeutic childcare at all, Humphrey? Is that community?
Oh gosh, I used to, and I've run child and adolescent services, but I leave that to the experts.
Oh, good, but it's in our arc. But to find out more about all of that, join me with John, 7 p.m. Wednesday, May the 28th. I did say 29th for us, May the 28th on Care Visions Professional Talks. Thank you, Humphrey. And until then, from all of us at Care Visions, goodbye.